Hello, and welcome to Lecture 3. I hope that you all had a nice Thanksgiving that wasn't too under pressure from your courses. I know it's very, very difficult to be a student and that your work's never done. I spent far too many years in school myself, so I really sympathize with you, and I hope it went well. This is an interesting lecture for me because it's something that I generally don't get a chance to do in introductory epidemiology courses. And the great thing about this course for me is that it enables me to go a little bit deeper into things than I would be able to in a typical introductory course. The first things we're going to be talking about today are really talking about the benefits and the challenges of evidence-based practice, and to elaborate why meta-analyses are important, and then finally describe the process of evaluating systematic reviews. You're going to be evaluating systematic review yourself as a project for this block, and so I want to give you a little bit of an introduction so you don't feel intimidated by it, because it really is a very straightforward process, and I think that you all have the skills that you need at this point to be able to really look at these things critically, which is what you must do if you're a public health professional. So just starting off with the definition of evidence-based practice, it's a judicious use. And notice the word judicious, because I think that sometimes people who want to put down evidence-based practice make it sound as though it's only about scientific evidence, but it's not. It's the judicious use of scientific evidence in making clinical and public health decisions. And in order to do that, you need to have the basic tools of epidemiology, because you can't really assess studies unless you assess really their validity. The relevance to clinical research or to public health is something that you also need to have, and that's probably more related to content. So if you're an expert in a content area, I think you are also better evaluating the relevance of any study, but with your basic skills of epidemiology, you should be able to evaluate the validity of any kind of study at this point. This kind of shows the Venn diagram of decision making in evidence-based practice. So you've got the best available research evidence, and then the resources that you have available to you, community resources, individual resources, and then the population characteristics, the needs, the values, and preferences of the audience or the population that you're working with. And so evidence-based decision making is anything but sterile, and it very much includes the context in which you're working. The context is incredibly important. The clinical work that I do in the United States is far, far different than the clinical work and the public health work that I do in Africa, because the populations and the needs and the values and preferences are very different. And so I think we need to be very conscious of those differences when we talk about evidence-based practice, and that really is an integral part of the model of evidence-based decision making. But the best available research evidence is an important aspect of it, and I think it sometimes gets left out. Human beings seem to like to make decisions based on anecdote or based on superstition, and I think if we're going to really put things on a scientific basis, then we really have to consider the best available research evidence when we go into any decision-making process. So just to review very briefly, the two major types of studies: experimental studies, that includes randomized controlled trials, and also quasi-experimental designs, so that, for example, a pre- and post-test type of study. So, for example, looking at the death rates of automobile accidents before and after the institution of seatbelt laws, or before or after the institution of airbags, or a before and after look at head trauma with bicycle injuries before and after use of helmets, and those sorts of studies. Those are also important studies. They're not really experimental studies per se, but they really have a lot of characteristics of that, the before and after type of studies. And then there are the strictly observational studies, or sometimes referred to as epidemiological studies, that you know very well: cohort studies, case control studies, cross-sectional studies. And then there's a very important type of study which we're going to talk about today, and that's the synthesis of existing evidence. So systematic reviews, that is meta-analyses, and also decision analyses and various types of decision analysis, cost-benefit analyses, and so forth. are all based on a synthesis of existing evidence. So if we look specifically at the hierarchy of evidence for treatment and prevention, you notice I'm not talking about harmful exposures here. We're concentrating more on treatment and prevention in this particular course. You can see that at the top of the hierarchy are the combined results of all randomized controlled trials, that is systematic reviews or meta-analyses. The next highest in the hierarchy would be a single randomized controlled trial. Then after that would be observational studies. And then finally, at the very bottom would be expert opinion or physiological arguments. So in the era that we were in before 1950, expert opinion was very important because there was so little clinical research published and so little good clinical research in particular. But the quality and obviously the volume of clinical research has expanded exponentially over the years. And so now we have a huge amount of evidence from, by and large, good studies, although it varies a lot. The important characteristic then of meta-analyses are that it's a systematic review, and that word systematic has a very specific meaning, which we'll talk about later, but it's a summary of the findings of all studies, that is, all relevant studies which attempt to answer a focused clinical question. It's otherwise known as a quantitative summary or a meta-analysis. Notice the word focused. So the fact that meta-analyses are focused on a specific question are a bit of a liability, because often in medicine and public health, we're not able to focus our question as well. But in order to be able to conduct a meta-analysis, you've got to have a very focused question. That is, the intervention has to be very focused and the outcome has to be very focused. And you'll see some meta-analyses which try and do too much or try and answer a question that's not well focused. And those generally are not valuable studies. The assumptions behind meta-analyses, which I'm going to try to show you a little bit later, are that experts' opinion may be biased. So the old model prior to the evidence-based practice model was that experts knew everything, and if you ask an expert about their opinion, they'd be able to tell you, and that would be the answer. But I think we've learned very well in the last few years that the medical industrial complex functions in a way that's very self-serving, that the drug industry is very involved in science, and that people who are experts many times are on the payroll of companies, and they're not always. In fact, they're frequently not completely unbiased. And so one of the challenges for us is to really get information that's not biased. And unfortunately, which I think I'll show you some examples of that a little bit later, experts' opinion is frequently biased. And the other assumption is it's better to review all the evidence than some of the evidence. What experts frequently do in a traditionally based review is they'll look at a certain amount of evidence, the evidence presumably that furthers their point of view, and they'll totally ignore any evidence to the contrary. So one of the bases of meta-analyses is that you look at all the evidence, not just the evidence that agrees with your point of view, and that you actually look at that in a critical way. And so simply because something's a meta-analysis doesn't mean that it's a good study. That's why I put GIGO at the bottom, garbage in, garbage out. If you don't have a focused question, if you don't have decent studies that address that question, then you're not going to have a meta-analysis that can draw any meaningful conclusions. And many meta-analyses are poorly planned and they're poorly conducted, and they really don't have the validity or the generalizability that we need. You're going to be working mostly with the Cochrane database, which has very high quality meta-analyses, but there's always a warning out there that may the buyer beware that with any type of consumption of information, you need to be able to have some way of evaluating whether or not it's valid. So the next study shows the traditional versus a systematic review. A traditional review depends on the author's inclination. The author chooses the references at will, doesn't really state the method of appraisal of those studies, nor how they combine the results of the study in order to draw a conclusion. So do they count the number of studies that are positive or negative, or how do they decide what conclusions they're going to reach? A systematic review, on the other hand, is a scientific approach to a specific question. And scientific means replicable. We'll talk about that in just a second, but it involves a comprehensive search for relevant articles. It involves explicit methods of appraisal and synthesis. And it can be used to quantitatively summarize data. Meta-analyses are most valuable when they summarize data from small studies. If you have a bunch of small studies in one very large study, it's not really very helpful because the large study is going to overwhelm all the small studies. And basically, if you look at the large study, you're going to come out with the same results. So meta-analyses, I think, is most helpful when it's a bunch of small studies. When there are also 3 very large studies, as in the case of circumcision, also circumcision to prevent HIV transmission, that is, also it's a less value because if there are only 3 large studies, you can look at those 3 large studies yourself and determine whether or not there are significant differences in those studies that would make you question the results. The advantages of a systematic review are that it reduces authors' bias because everything is very explicit. That is, that if you wanted to replicate the same meta-analysis, you could do exactly the same search, you could find the same studies, you could evaluate the same studies, decide which to include or not to include. And that's what makes it a scientific process. Science is based on replicability. Laboratory science, you can replicate the experiment in the lab. Clinical studies, you can repeat the clinical study and get about the same results. So that is what makes systematic reviews or meta-analyses scientific. You can also identify, explore, and perhaps resolve conflicts among existing studies, because existing studies are never going to show the same results. And so it may simply be because of lack of precision. That is, small studies are going to vary in the results just based on small sample size. And it also enables you to identify gaps in the current knowledge in order to be able to plan for future studies, and ultimately, as well, identify beneficial or harmful interventions early, prior to the time when there's a huge landmark study done that totally resolves the issue. So let me start now by giving you an example. And this is an example that I'm very familiar with because in the early part of my training, beta blockers, common drugs like propranolol, metoprolol, atenolol, drugs that are very commonly used that block the beta adrenergic receptors, primarily in the heart and the lungs. And they're very good antihypertensive medications, but when I was at the early part of my training, one would never have given a beta blocker around the time of a myocardial infarction or heart attack, because one of the effects is they reduce cardiac output. They reduce the contractility of the heart. And since when somebody has a myocardial infarction, you'd be very worried about giving them a drug that would reduce myocardial contractility. But here, this shows a meta-analysis here, and you can see each study is put on this graph, similar to what you had in the quiz, and that's why this quiz was so important, because you're going to see this graph time and time again. Every time you read a meta-analysis, it had better have one of these graphs. If it doesn't, then you're in trouble. So the outcome we're looking at is death after hospitalization. So the focus question of this meta-analysis is, does giving a beta blocker after a myocardial infarction reduce overall death rates? And you can see at the top, just to be clear, it says favors beta blocker, or on the right, favors placebo. And you have the relative risk equal to 1. So you can see the first study was done in 1972 with 77 subjects, and it showed a relative risk of 1 with wide confidence intervals. Okay, the second study was done in 1974 with 230 subjects, showed a relative risk of about 0.5, and the confidence interval overlapped 1, so we'd say it wasn't statistically significant. 1974, 162 subjects, again, a relative risk favoring beta blocker, but not statistically significant. But then in 1977, a large study with over 3,000 subjects was done, and that did show a relative risk. It's about 0.6, and it was just statistically significant. In other words, the p-value was 0.05 because the confidence interval just came to 1 but didn't overlap 1, etc., etc. So you can see there are 1, 2, 3, 4, 5, 6, 7 studies here. And then the overall summary of those relative risks is shown in the yellow overall by adding up the total number of subjects. So if you include the subjects in all the studies, which were conducted similarly, they all had the same outcome, death after hospitalization. The patients were all given beta blockers. I'm not sure if they're given all the same beta blockers or different ones, and that would be an important thing to see because perhaps some are more effective than others. But nonetheless, if you look at this meta-analysis as of 1984, it was pretty clear, even though there was quite a bit of heterogeneity or variability among the studies, and the first studies in particular didn't show a benefit, but the larger studies later on did, and such that the two large studies, one with 3,000 subjects and one with almost 1,900 subjects, both showed a statistically significant benefit. And because those studies were so much larger, of course, the overall average shows a relative risk of about 0.6, which is statistically significant. So this is an example of a graphical representative of meta-analysis. This is the situation in 1972. So in 1972, there was only one study, as I mentioned, with 77 subjects, and it didn't show any benefit. The relative risk was 1, and there were wide confidence intervals. And in 1972, you'd have to conclude that beta blockers were not indicated for use after myocardial infarction. So it wouldn't have been appropriate to use them at that time. In 1974, after 2 more studies were published, both in 74, now you have overall, you've got 469 subjects in those 3 studies. And the confidence interval still overlapped 1, so it wasn't statistically significant. But you'd have to say, well, it's possible there's effect. We can't conclude there is an effect, but the relative risk is certainly quite a bit less than 1. It's about 0.6. So perhaps the fact that there's no effect simply is a lack of statistical power or lack of precision. The studies haven't been large enough, okay? So in 1974, one would, I think, conclude, if one did a meta-analysis at this time, which it wasn't done because meta-analyses were not done at this time, I think a logical conclusion would be that it's probably not a good thing to recommend. Now here you can see that at the end of 1977, it does suggest that there's a benefit of beta blockers because the overall confidence interval, the relative risk was about 0.6, and the overall confidence interval no longer included 1. This was based on the large effect from the study with 3,000 participants, and a study with 3,000 participants is going to overwhelm the results of those smaller studies. But 2 out of the 3 of those smaller studies also showed a possible effect. It's simply the studies didn't have sufficient power. They weren't precise enough. The confidence intervals are wide. So a possible conclusion at this point would be that beta blockers did reduce death after myocardial infarction. Now this is an interesting slide because this shows a cumulative meta-analysis. Now we're talking about looking at every time period and including all the studies that were done prior to that time period. So in 1972, there was only 1 study which showed a relative risk of 1. In 1974, now there were 3 studies, okay, and they showed with 469 patients, and again showed a relative risk less than 1, but included the relative risk of 1 in the confidence interval, so it wasn't statistically significant. And then in 1977, besides the 1 study with 3,000 patients that we mentioned earlier, there were 3 other small studies, and again the confidence interval no longer included 1. And then in 1980, now we've got a total of 6 studies, and now we've got 4,353 patients, etc., etc. So every year there were more studies that were added, more subjects, and so by 1983 there have been a total of 14 randomized control trials with 14,607 subjects. And I think at that point the evidence was overwhelming that beta blockers were beneficial in reducing death after myocardial infarction. So the researcher that did this, Elliot Antman, who's a cardiologist, looked back. He did this cumulative meta-analysis we're looking at, looked at these graphs, said, look, by 1977, it looked like, based on those 4 randomized controlled trials, that beta blockers reduced death from myocardial infarction. Well, let's look back at the textbooks of the time and see how the experts evaluated at that time. So you can see this is the number of textbooks and reviews that he reviewed. And so in 1972, there were 2 reviews. They didn't mention it. Another 8 reviews in 1974, 5 reviews in 1977, 6 reviews in 1980, 11 reviews in 1981. Even though it was quite evident, it would have been quite evident by the cumulative meta-analysis as early as 1977 that beta blockers could reduce death after myocardial infarction. Nobody even mentioned it until 1981 when 1 reviewer mentioned it and recommended it. And then in 1982, then people started recommending it and mentioning it and recommending it, although 2 textbooks recommended against it. And then after the meta-analysis was published in 1983, which was the first meta-analysis of the subject, textbooks started recommending it. So the point of this is the experts were really, they didn't really start recommending it until 1982, and they could have recommended it as early as 1977, 5 years earlier, and could have saved many lives if they'd used this sort of analysis at the time. Okay, so this is evidence that meta-analyses actually are helpful, and that expert reviewers can sometimes either be biased or not get the right answer. At that time, cardiologists, interestingly enough, were recommending calcium channel blockers after MI because there are some physiological arguments for doing it. Again, here you can see a cumulative meta-analysis of calcium channel blockers post-myocardial infarction. On the left of the relative risk 1 line favors the treatment with calcium channel blockers. On the right side favors placebo. And you can see there are 4 randomized controlled trials done in 1984 that suggested that it actually might be harmful. And at that time, textbooks recommended it. Two recommended they give it, 3 recommended against it, and 8 of them didn't mention it. And in 1985, now with a total of 7 studies, 1986, a total of 11 studies, it became increasingly obvious, even though the confidence interval still included 1, that calcium channel blockers probably weren't beneficial, that they might actually be somewhat harmful. And you can see that textbooks continued recommending calcium channel blockers right up to the time when the meta-analysis was published in 1988. Here's one more example. This is prophylactic lidocaine. So based on the work of a Maine doctor, Bernard Lown, who was a physiologist and a cardiologist, who was working in Boston, graduated the University of Maine. He came up with the idea based on his studies of neurological irritability after myocardial infarction in dogs, that if you gave lidocaine, which stabilizes the membranes of nerves after myocardial infarction, you could actually reduce death rates. And so it became very fashionable every time we had somebody with chest pain that was admitted to the ICU when I was training, we would also always give them intravenous lidocaine, and it had a lot of side effects too, and people went crazy with it. And but we thought we were saving lives that way. But come to find out, even as far back as 1970, which was well before the time I trained, there were randomized controlled trials that showed that it wasn't beneficial, and it could have even been harmful. Again, the relative risk was about 1.3, and the confidence interval overlapped 1, so we couldn't say one or the other. But if you look at the right hand again, the textbooks were all recommending it at that time, in spite of the evidence that it was actually harmful. And even as late as 1988, when the meta-analysis was published, showing no beneficial effect, 14 textbooks and reviewers still were recommending it, and even as late as 1990. So again, just an illustration of the fact that experts can be wrong, and it's probably better to look at all of the evidence and look at a biased selection of the evidence. So now we're going to talk about the source for meta-analyses, which is the Cochrane Library, and it's the Cochrane Library that you'll be using for your project. So the Cochrane Database of Systematic Reviews has approximately 8,000 systematic reviews in all topics. They're primarily oriented around treatments, about preventive and therapeutic interventions. There's also a database of abstracts of reviews of effects, the so-called DARE database, which is part of the Cochrane collaboration. And those are abstracts of systematic reviews. And then there's the Cochrane Central Register of Clinical Trials. And I'll talk a little bit about this at the very end of the talk today. So you'll be using the Cochrane Library for this week's group project, or for the next 2 weeks group project. And all you need to do is go to the UNE Library online, search for Cochrane Database of Systematic Reviews, click on it. When it comes up, search for one of the topics listed in the syllabus. If you want to do a different topic, then it's fine with me, but just check with me first and make sure that I think it's a good topic to do. And just a caution, look at the PDF version. I'm not sure why, but the ones I looked at, the HTML version, seems to only have the abstract. It doesn't have the complete review, and you're going to need the complete review for doing your project. So look at the PDF version. That should have the complete review on it. So the first Cochrane review I just want to talk to you about, explain to you. And it's not an intimidating thing. But I think if we walk through it, you'll feel a lot better about it, because it is a scary name, meta-analysis. And so this is a review from the Cochrane Library, Antibiotics for Acute Bronchitis. So 70% of patients who are diagnosed with bronchitis are treated with antibiotics. And antibiotics, as you know, are a two-edged sword. They're life-saving when they're used appropriately, but when used inappropriately in human and in veterinary medicine, they can be very problematic. They have side effects, they have costs, and as you know, we're very concerned about microbial resistance from inappropriate use, and it's getting worse, so that there are now infections that are completely untreatable, just like in the pre-antibiotic era. So this is the title, Antibiotics for Acute Bronchitis. The authors, shows where the authors come from, the contact address, and the citation. Okay, so this was 2012 review, antibiotics, and this was actually a re-review. It was a review that was originally done, and then it was updated in 2002. You can see there it says edited, published in June, issue 4, 2012. Review content assessed as up to date, 6th of September 2010. So it does take a little while for those studies to come out and get incorporated, about 2 years. And you can see again below that, the original review was in 2004. And the 2012 edition made no substantive changes to the conclusions, but they did update it with some new studies. So this particular meta-analysis considered only randomized controlled trials, since this was a study of a treatment intervention. And treatment interventions, randomized controlled trials. Bronchitis is a clinical syndrome of cough with sputum production, or they considered also a doctor's diagnosis of bronchitis. And they excluded studies of chronic bronchitis among smokers and people with pre-existing lung disease, for example. And the outcome definitions are a very important part of any meta-analysis, any systematic review. And the outcome measures that they used were time to resolution of cough, sputum production, activity limitations, proportions of patients with cough, night cough, productive cough, activity limitations, etc., global assessment of improvement by clinicians at follow-up, and adverse events. I'm not going to talk about all these outcomes, but the first thing you need to do once you look at a meta-analysis is see if you think that the intervention they're talking about is focused sufficiently, because antibiotics is a very broad term also. It could be that some antibiotics are effective and some are ineffective, and that might be a way you could get at a question like that with a meta-analysis. If you see that certain antibiotics show effects and other ones are ineffective. But this is one of the steps in determining whether or not the meta-analysis is valid and important. The next step is that you really have to conduct, or the authors of the meta-analysis have to conduct, a comprehensive search for published and unpublished randomized controlled trials. So here in this review, they say, for this updated review, we searched the Cochrane Registry, we searched Medline, etc., etc., and they give a long list of the searches they did at Medline, the actual searches they did. So if you wanted to repeat the search, you could, and I cut off at the bottom, I didn't show them all because it goes on and on how they search for it, but you could repeat the search yourself, and presumably you'd come up with the same studies. And if you think they selected out the wrong studies, you could redo it with the studies that you thought were important, or you could at least criticize their work. Interestingly enough, they said, we also searched the reference lists of relevant trials, review articles, textbook chapters, including those published prior to 1966. We included articles from the author's personal collections. We requested unpublished trials from trial authors. We contacted drug companies that manufacture antibiotics, etc., etc. And there were no language or publication restrictions. So they tried to make a comprehensive search for all articles. And then after that, they excluded some studies because they didn't think those studies were really appropriate. So if you look here, the study Batea 2002, 185 patients with acute respiratory tract infection from 2 health centers in Jordan. Assignment to antibiotic was by means of alternation, not randomization. So it wasn't a randomized controlled trials. So therefore they excluded it. And then the next one, 2004, RCT concerned with application of a diagnostic test. So it wasn't actually a test of whether antibiotics were effective or not in acute bronchitis. Now we see just an excerpt from the figure 2 in the meta-analyses. Risk of bias summary. Review authors' judgments. So each of the review authors judged the validity of each study, and then they compared their results independently, compared their results to try and iron out difference about each methodological quality item for each included study. So you can see if you turn your computer sideways, the quality items aren't all that esoteric. The first one is random sequence generation, so were they really randomized. Second one, allocation concealment. So that refers to whether the actual investigators knew how the allocation was conducted, how it was randomized. Blinding, okay? Blinding for all outcomes, and then blinding, I'm not sure why they include all outcomes and why they include 2 blinding categories here. Incomplete outcome data, selective reporting, or other bias. So each of these studies was assessed for bias, all right? Each of the studies that was actually included. And you can see the second study here in this table is Dunley, 1987. It looked like there are green dots in each one of those, which suggests that they didn't find problems with bias or the lack of validity in these studies. And then the next slide shows you, this was the Dunley study, 1987, the methods, who were the participants. It was a double-blinded RCT. What were the interventions? So they took erythromycin in this case. And what were the outcomes? All right. So this is a little bit of a summary of this study. And then this is the same Dunley study. They said, okay, they thought that in the author's judgment, the random sequence generation was a low risk for bias, and these other outcomes, which are their criteria, which we saw in the graph previously, were all low risk for bias. So they thought this was a study that had low risk for bias. That's why all those little green dots were there. And then subsequently, they made a graph showing all the studies together. So this is the risk of bias graph. Review authors' judgments about each methodological quality item presented as percentage across all included studies. There are 15 studies here, so you see that there was at least one study in each of these 3 categories: blinding, the 2 blinding items, and then the other bias items. So I don't know whether those are all the same studies, but other studies or different studies. But 14 out of the 15 studies in each case were green. That is, I think those represent about 1 out of 15 at any rate. And then you can see one is yellow, selective reporting bias. So there was unclear risk. So again, 15 randomized controlled trials. Outcomes were pre-specified by the Cochrane researchers, but not all studies included all outcomes. Some studies included some outcomes. Some studies included other outcomes. So for each outcome, you're not going to have a complete list of 15 studies. So let's look at this outcome. This is the first outcome. So this is a forest plot, the same kind of plot. And it's interesting because You can see the sample size also is related. The little dot, which indicates relative risk, is also related to the sample size. The bigger the sample size, the bigger the dot, or in this case, this little square. And you can see the confidence interval represented as well by the line. So that first study, Dunley, the one we talked about in 1987, there were only 14 events, that is, cough at follow-up visit, 23 patients total in the antibiotic group, and only 22 patients in the placebo group. So this is a very small study, and you can see that even though it was a small study, it had a weighting of 26%. In other words, that cumulative relative risk, which is shown right at the bottom as a total, 24% of that comes from this one study, which only included 45 patients. So these are very small studies. The second study, which only included 11 patients in the antibiotic group and 9 in the placebo group, 20 in all, showed no benefit of, and again, look at the bottom, it says favors placebo versus favors antibiotic on the left. So you can see that 3 out of the 4 studies, none of them were statistically significant. That bottom one actually was. If you look the risk ratio for the Williamson study, the risk ratio is 0.51 and the confidence interval was 0.27 to 0.96. And the other one actually above it was also statistically significant. The confidence interval did include 1. It's a little bit hard to see on the graph, but if you look closely, it is definitely doesn't include 1. So those studies were statistically significant. The other 2 studies weren't, including the largest study, but the cumulative summary relative risk then is 0.64 with a confidence interval of 0.49 to 0.85. So we can say that in all patients included, that is the 143 total patients including the antibiotic group and the 132 included in the placebo group, and all those 4 studies combined, there was a trend that was statistically significant that suggested that the cough was less at the follow-up visit. Fewer patients had a cough at the follow-up visit if they were treated with antibiotics. And if you look below also, it talks about heterogeneity. It gives you a chi-square test for heterogeneity, and the p-value is 0.22. So that even though the studies obviously didn't show the same relative risk, when you have small studies like that, you're going to have a certain amount of variability in precision. And that chi-square test for heterogeneity doesn't suggest that the studies were really that different. The differences you saw between the study were probably just based on random error and not on any sort of bias from those studies. So here's a forest plot of night cough at follow-up visit. So this is the number of patients with night cough. So you can see the Dunley study is represented again. Only 4 studies included this outcome. And the largest of those studies was with the Matthews study of 2000, which had 171 patients in the antibiotic group and 169 in the placebo group. And the relative risk was 0.65, and the confidence interval of that study didn't include 1. So that study is the largest study, much larger than the others. The weight of that study was 81%. So that total relative risk estimate, 81% of that is based on that one study, the Matthews study of 2000, and again showed less night cough in patients who were treated with antibiotics. Again, the p-value for heterogeneity was less than 0.05, which suggests that the studies were not heterogeneous. The reason why they showed somewhat varying results is just because of random variation. Then here's this graph, forest plot of comparison, days of feeling ill and mean number of days of feeling ill. So this is a mean difference. Now we're not talking about a relative risk here. The null value of mean difference is 0, not 1. And you can see the mean differences are listed here. And none of them are statistically significant. But when you look at them all together, and that's the whole point of meta-analysis, you're combining small studies, the mean difference is 0.58. That is a 0.58 mean days difference of feeling ill. So the patients who received antibiotics were less ill, or were not ill, or got better 0.58 days sooner, that is, than the ones who didn't take antibiotics. And the relative risk doesn't include 0, which in this case, because it's a mean difference, is the null value. So in fact, it goes right to 0. And so we can say that it's statistically significant with a p-value of 0.05. And you can see that actually in the bottom. It says test for overall effect, chi-square p is equal to 0.05. So here's the last comparison. This is a number of patients with adverse effects. So it's very important in any study to look at adverse effects. And so almost all of the 15 studies included adverse effects. And you can see that among those who took the antibiotics, it wasn't statistically significant, but there was a trend towards more adverse events in those who took antibiotics. And the adverse events primarily consisted of vomiting, nausea, headache, rash, and vaginitis. So clearly that whenever we talk about any therapy, we've got to compare the benefits with the adverse events as well. So in conclusion, I think you'd have to say that for acute bronchitis, antibiotics do have some small benefit, but the benefits are not large, and clearly as well the adverse effects antibiotics are also probably larger, although again, in this case, they weren't statistically significantly different. So here's another meta-analysis, again from the Cochrane Library, for antibiotics for acute maxillary sinusitis. In this case, sinusitis was defined as having a consistent clinical history and x-ray or aspiration evidence of sinusitis. That is, they stuck a needle into the sinus and determined, and also the patient had to be sick for less than 30 days. So again, they included only randomized controlled trials of antibiotics versus control, and only in adults. And this just shows the results. Again, there are only 2 studies. They're both small. The Lindbeck study included only 45 patients in the experimental group or the antibiotic group. This is, in fact, all these used amoxicillin. And the control group, 44, and the other study, 108 and 106. So you can see that the Lindbeck study showed an odds ratio. That's a pedo odds ratio. It's simply a type of odds ratio of 4.3, and the other showed an odds ratio of 1.48. And the overall summary odds ratio was 2.09. That again was statistically significant because it was greater than 1. So in this case, it did favor amoxicillin for acute maxillary sinusitis. The outcome, clinical cure or improvement. And I don't know exactly how many days that was. Another antibiotics for acute otitis media in children. 10% of children have otitis media by 3 months. I'm sure many of you had otitis media or had children with otitis media. And antibiotic use varies tremendously. Only about 31% of kids with otitis media get antibiotics in the Netherlands versus 98% in the United States. Again, this is a Cochrane review. 7 randomized controlled trials included patient-relevant outcomes, including now a larger sample. All the studies included. Those 7 randomized controlled trials were over 2,000 children. And the reviewers felt the trials were good quality. And so here you can see again the forest plot for that. And you can see that there were actually, if you look at pain at 24 hours in the studies, there's no statistically significant difference. The odds ratio is very close to 1. If you look at pain at 2 to 7 days, you can see there was a small benefit of antibiotics at that time. Again, the total relative risk is, what is that relative risk? Pedo odds ratio, I think it says 0.61, and it's statistically significant. And again, as you expect, these are this is late recurrence here, and it doesn't show any benefit preventing late recurrence. And then this is vomiting, diarrhea, and rash. And as expected, again, the children who received antibiotics had a higher rate of vomiting, diarrhea, or rash than kids who didn't. So when we talk about meta-analyses, we need to look at them as though we do any other study, and we have to really assess the meta-analysis for validity. Was the search comprehensive? Were the inclusion-exclusion criteria appropriate? This time they're including and excluding studies, not individuals. Did they only include randomized controlled trials, or did they also include cohort case control studies? And if they did include them, what was the rationale for doing that? And did they show the results separately, or did they combine randomized controlled trials and observational studies together? Were the studies similar enough to combine? This is addressed the question of heterogeneity, both in terms of outcomes and in terms of exposures, or interventions. So did they use all the same antibiotic, or did they use different antibiotics, beta blockers? Did they use the same beta blocker or different beta blockers? So we have to have a certain amount of content information in order to be able to assess that. Did the authors evaluate the studies for bias? And if there were studies they thought were very likely to be biased, how did they deal with those? Did they include them or exclude them? Was the quality sufficient to combine? Should you exclude poor, likely to be biased studies, or include them? Or do a sensitivity analysis, which in one hand includes them and in another hand excludes them? Were the interventions and the outcomes similar enough? And were the results similar or all over the board? So your project this time is to just complete a critical appraisal worksheet for meta-analyses. There are critical appraisal worksheets for all study types, and you're going to be doing this one. You're going to be completing the worksheet for one meta-analysis. It should be a straightforward exercise, and the Cochrane reviews generally are very high quality and use the same methodology, so you probably won't find too much trickery here. But if you read meta-analyses that are in medical journals or public health journals, you might find some trickery, and you may find important studies that were excluded, or studies that were included that were biased, and so forth. So I think it is really an exercise in critical appraisal. The questions you're going to be addressing specifically is, first of all, what question did this systematic review address? In your case, was the exposures likely to be a treatment? And you have to ask yourself, is the question focused on a specific intervention? Remember, that's one of the strengths and weaknesses of meta-analysis. One of the strengths is that it focuses on a particular intervention. The downside of that is that the question may be more general than that, and you may not want to focus on a specific question. So, for example, if we look at the effect of diet, are we talking about only the component of magnesium, or are we talking about the component of magnesium with all the vitamins, etc., etc.? Because things work in combination. They don't just work separately. And so if you're going to be focusing on diet, it'd be very difficult to just focus on particular components of the diet, because the diet is so complicated, and developing a specific question can be very difficult. Second, were important relevant studies identified? What was the search strategy? Was the search strategy comprehensive enough so that it was likely that they identified all relevant studies, not only the published ones, but also the unpublished ones, not only the ones in English, but also the ones in other languages? Were the criteria used to select the studies for inclusion predetermined, clearly stated, and appropriate? So if you wanted to repeat the meta-analysis yourself, and you could replicate it in the same way they did. Number 4, did the investigators evaluate the studies for validity? Number 5, were the results similar from study to study, or was there heterogeneity? And if there was heterogeneity, why was there heterogeneity? And finally, what were the results? Were they precise? That is, were they statistically significant? And were they clinically important? And do you agree with the author's conclusions? So this is your task for the project, and I think it's pretty straightforward. And again, the objective of doing the project is to get you familiar with the Cochrane database. Look at it critically, and look at an entire review instead of just looking at the abstract. Appreciate how the review is done, and try and be critical. So you may find some of them where you may disagree with the findings, and if that's the case, I'd really like to know, because there aren't right or wrong answers here. Finally, the last thing I like to talk about today is publication bias. And publication bias, I think, is one of the most vexing problems in medicine and public health. And the problem is that intervention studies that are negative are unlikely to be published. If the investigators find negative results, then they're likely to put them in a drawer and not bother to publish them, And publishers also are less likely to publish studies that are negative because they're a business just like every other business, and they want eye-catching headlines, and so they're much more likely to publish studies that show positive results. Who wants to publish a result that's negative, that shows an intervention is not effective? And the result is that published studies may not be representative of all studies done on a particular question and may be biased in the direction of finding a treatment effect. And so some of the treatments that we take for granted that are effective, that scientific evidence has shown to be effective, if there were a lot of other studies that were never published because they didn't show an effect, then that intervention might not be effective after all. We might be fooled by this problem of publication bias. And publication bias has been recognized as a very serious, and as a solution, or at least a partial solution, the major medical journals have collaborated, and they supposedly, although studies have been done which show they don't always adhere to this, they should refuse to publish any intervention study if it hasn't been entered into an international database like clinicaltrials.gov or the Cochrane database prior to the enrollment of subjects. So that if an investigator agrees to enroll in one of these databases, then you're going to need to publish the results on the database, whether or not the results show a positive benefit. And so this assures that when people conduct meta-analysis in the future, they'll also be able to find studies that didn't show a benefit and be able to include those in the meta-analysis by either searching Cochrane or clinicaltrials.gov for unpublished studies that didn't get published for various reasons. And so publication bias is a very serious problem, and I think has biased a number of our treatments so that we think they're effective when they're actually not. And this is one, at least partial solution to the problem of publication bias. So meta-analyses are certainly not the only answer. I think they're valuable tools that enable us to learn and to be informed about the best current evidence. But again, you have to be suspicious, you have to review, you've got to be critical and evaluate meta-analyses to see if they're actually telling you the truth. So that any study can be erroneous, any study can be biased. And one of the objectives of learning epidemiology in this course is to make you skeptical of published results and make you be critical and actually look to see if you're yourself convinced that any particular intervention is beneficial. That's the end of the lecture, and please be in touch if you have any questions. But I hope this was an introduction to meta-analysis, which I think is an incredibly important tool. Thank you.